going in a reverse way. Second lecture is now second. Dr. Jiten Vora is going to talk on a very important aspect, that is a nephroprotection in type 2 diabetes, contribution of newer therapies. Dr. Jiten Vora is from United Kingdom. He is a clinical director for pediatric department of Dartford of NHS since 2015. He is also dealing with the diabetes of the children and young since last more than 15-17 years. He has served in various hospitals and external committees, and Professor Vora's ongoing research interests include the development of screening and treatment of diabetic retinopathy, renal hemodynamics, and hypertension in type 2 diabetics, the prevention of renal disease in diabetic, the physiologic of aspect of treatment of type 2 diabetes, and mechanism of osteoporosis. Professor Vora has also published extensively in the field of diabetes and endocrinology, and he has also served on many advisory panels, including the NICE, which are the guidelines we use for many diseases, particularly lifestyle diseases. So over to Dr. Jiten Vora for his talk on nephroprotection.
Thank you very much. Thank you for those kind words. I have to say that some of that is not related to me. I'm not a pediatric endocrinologist, nor have I ever been. I've always looked after adults, but the rest of it is fine. Thank you very much for asking me to participate in this trial. I'm honored to be part of the DiaCare conference on this occasion. Now I'm trying to make this work, which I'm not doing at the moment. Are we all good, Banshi? Can you see my slides now?
Yes, sir, we can see you.
Yes, yes.
So, thank you. So thank you very much for asking me to participate in the DiaCare conference for 2020. I'm honored to be here. Let me start with some background points. We know that there is a huge population with patients with type 2 diabetes. We also know that somewhere of the order of 30 to 40% of those patients will develop a degree of renal impairment, as measured either by eGFR reduction or an increase in albuminuria. 10% of those patients will still develop end-stage renal disease. So the numbers that we deal with are large, and there's a large residual risk despite all the other background therapies that we should be using, standards of care. So with that background, what I'd like to do in the next 15-20 minutes is to cover the SGLT2 trials and what they mean to us in terms of potential prevention of renal disease, secondary prevention of pre-existing disease, i.e. delay the progression and or possibly regress, and then the treatment of established renal impairment. And we will talk a little bit about the GLP-1 receptor agonists. So let me start you off by looking at this KDIGO trial. You are all very familiar with this. On the y-axis, we have eGFR categories, and you will see that at the top left-hand corner, we have a eGFR of 90 and then gradually declining as we come down. On the x-axis, we have median urinary albumin creatinine ratio increasing from left to right. Now, I put this up because it demonstrates the risk and it allows us to consider the data that I'm going to present to you in relation to the risk. You will see that the trials on the left, Canvas and Declare, were predominantly the low-risk groups, with many people having normal eGFRs and very low levels of albuminuria. And then we move to the EMPA-REG trial, where the number of people with GFRs in grade 2 increases, as does the albumin excretion rate. And finally, on the right, we have the CREDENCE trial in people with established renal impairment. So we know by looking at the outcomes, the primary composite outcomes of all of these trials, that they've demonstrated an improvement in the renal composite endpoints. May that be related to empagliflozin, canagliflozin, dapagliflozin, or indeed canagliflozin. So this is a class effect. And also note that the reductions, the improvements in outcomes are about the same in every trial. So they're reducing outcomes by about 40 to 50% consistently. So let us then move on to the possibility of regression or prevention of development of kidney disease. We've noticed that somewhere of the order of 30 to 40% of our people will develop renal impairment, either as measured by eGFR reduction or an increase in albumin-creatinine ratios. The DECLARE study is a particularly prominent study. If you look here, in patients in the DECLARE study, the GFRs were in 85, median GFR was 85 and a very low level of albuminuria. So these were essentially renally very healthy patients. And despite that, as you can see on the curve on the right, there was a halving of the development of the renal composite endpoint. So to me, this indicates that by using these compounds early, as here it's dapagliflozin, we are actually reducing the development of renal disease in people who otherwise had normal renal health. So this is evidence of primary prevention of kidney disease. Prevention of kidney disease to reduce those number of people who at the moment are of the order of 30 to 40%. Similarly, if we look at the data from the EMPA-REG and CANVAS trials, you will see that the benefit of these two drugs in these two trials were related to every stage of renal development, including up at the top, the new development of microalbuminuria. So we've seen that deterioration of eGFR is reduced, as is the development of new albuminuria. Of course, in these trials, we also saw that the benefit was present for every stage of renal impairment, either the development of macroalbuminuria or end-stage renal disease or doubling of serum creatinine. So there is evidence now of prevention of kidney disease in people with type 2 diabetes, either measured by eGFR or measured by albuminuria. Now, so the important question for us clinicians is, do we have to check the eGFRs before we initiate SGLT2s from the perspective of renal prevention, renal protection? The answer to that is no. In here, on this slide, in this figure, you will see data from the three biggest trials demonstrating that the benefit of SGLT2s in renal disease is present regardless of your baseline eGFR. So at the top, we start with the highest GFR greater than 90. And you can see that there is approximately 60% benefit of the SGLT2s. And as we go downwards, we go to groups with lower GFRs, and you will see that the benefit is still present because the hazard ratio is to the left of the line of unity. So SGLT2s demonstrate benefit in every patient regardless of the eGFR, and also demonstrate the possibility of prevention of kidney disease. The same is also true for baseline albumin-creatinine ratios. So here again, we have data looking at going from the top, normal albumin-creatinine ratio, increasing albuminuria as we decline downwards, and you will see that the hazard ratio is again to the left, demonstrating a benefit is present regardless of baseline albuminuria. So let's just summarize the data so far. We've shown you some data that shows that there is possibility of prevention of kidney disease, particularly from data from the DECLARE, but also to a certain extent data from EMPA-REG and CANVAS. Benefit of SGLT2s in terms of renal endpoints is present regardless of baseline eGFR and baseline albuminuria levels. So what happens in these trials to the eGFRs? So here we have EMPA-REG on the left going to CANVAS and DECLARE. As you go to the DECLARE study on the right, please note that the y-axis is a different scale. So all of these trials show you an initial reduction of GFR with SGLT2s, but thereafter a stability. So in the EMPA-REG, the baseline GFR was 76 or so, and it remained stable. Similarly in CANVAS. And if you remember, the eGFR in DECLARE was 85.2, and that too remained stable over the course of 3 to 4 years. So the stability of GFRs is also reversing the natural reduction of GFRs that we see in people with type 2 diabetes, which is of the order of 1 ml per minute per year. So even the natural reduction of EGFRs is protected by using SGLT2s. Now let's just summarize the data for albuminuria and protein excretion. This is quite a complex slide, so let me take you through it. On the left-hand end, we have primary prevention or progression of disease, or at the bottom, regression of disease. And as we go to the right, we have the three big trials. So if we stick to the top left-hand panel, this is primary prevention. So this is looking at people who are currently normoalbuminuric, who may develop micro or macroalbuminuria. And you will see as you go through the three trials that there is a 20 to 25% reduction in the development of micro or macroalbuminuria. Again, exemplifying the data for primary prevention. Then if I could take you back to the left-hand panel again, then the next two are relating to progression. People who have normal or micro and develop macroalbuminuria, or normal microalbuminuria develop either abnormal proteinuria. And the point to note here is as you go through the study, anywhere between 30 to 40% reduction is witnessed in these trials. And finally, at the bottom, we see regression of proteinuria. Now, you know that regression of proteinuria also means an improvement in cardiovascular mortality. So the bottom line shows you a regression, a reversal of the current proteinuria level to the level below in over half the people. So what this slide does is it summarizes a huge amount of data showing you that not only EGFR results demonstrate primary prevention, but also albumin excretion rate. Albumin excretion rates also demonstrate the reduction in progression of pre-existent disease. And finally, there is a major regression of the level of proteinuria in these patients. So as a package, the GFR and the albuminuria data shows you primary prevention, prevention or secondary prevention of disease, and finally, an improved regression of albuminuria. So let us now turn our attention to the right end of this KDIGO risk chart. That is the CREDENCE study in people with established renal disease in whom the risk of renal progression as well as cardiovascular disease is huge. And again, as in keeping with all the other trials, in these people whose mean GFR was 56 mils per minute and an albumin excretion rate of 927 milligrams per day, so we're talking about people who have significant renal impairment, again, there was a 40% reduction in the renal composite endpoint. And the panel on the right shows you that that balance of that protection is present for the development of end-stage renal disease or at a slightly earlier stage of development of doubling of serum creatinine. So these are hard endpoints demonstrating a 40% reduction in this otherwise extremely high-risk group. Also in this group of patients, the GFR was maintained. So in the blue here, you see canagliflozin, and in the orange, you see placebo added on to standard of care. And what you can see here is that there is at least a halving of the decline of eGFR. And what that means is that you will delay end-stage renal disease by anywhere between 10 to 12 years, having therefore cost implications as well as societal implications. Now, the latest study to report is the DAPA-CKD trial. As you can see below, it was in a group of people who had an eGFR between 25 to 75, albumin creatinine ratios of 22 to 565, and they had either diabetes or no diabetes, but they had glomerular disease. And in these patients, what you find is, here is the placebo arm with 312 events, renal composite endpoints, and in the blue we have dapagliflozin with 197. So it's almost a halving of events. So the hazard ratio is 0.61, so a 40% reduction in the development of a renal composite endpoint in a group of people whose baseline GFR is 43 and our baseline albumin creatinine ratio is almost 1 gram per day, and 67% of them had diabetes. Now, the important thing, of course, we all know is that in people who develop end stage, who are developing declining eGFR or an increasing albumin-creatinine ratio, is that their cardiovascular mortality increases, all-cause mortality increases. So it is important for us to look at all-cause mortality in these patients. And indeed, what you find here is that all-cause mortality will also decline in this group of patients. So here we have data on just all-cause mortality in DAPA-CKD, and you will see that there's a 30% reduction in all-cause mortality. So in people with and without diabetes, GFR of 40, 1 gram per day, 67% had diabetes. You reduce their progression to end-stage renal disease of doubling a serum creatinine by 40%. That data is exactly the same for people with diabetes or those without diabetes. Furthermore, you see an improvement in all-cause mortality in an otherwise very high mortality group of patients. The most important thing here is that finally the DAPA-CKD study shows you that when the treated GFR of reduction of 2.86 mils per minute is half compared to all the other renal trials that we have seen. So this goes a little bit further in addressing the residual risk of patients with renal impairment, particularly with type 2 diabetes. It's important to notice, of course, also that the use of SGLT2 in patients with heart failure. So you're using SGLT2s in heart failure trials, and what is the outcome of the renal outcome in this study? You and I all know that these patients sometimes have limited treatment options because of renal impairment. However, in the trials, DAPA heart failure and EMPEROR reduced, the use of SGLT2s demonstrated the reduction of development of renal endpoints whilst being treated for heart failure. So even in people in whom there's heart failure but not pre-existent kidney disease, there is a reduction in a protection from SGLT2s. Furthermore, and the most important finding in this group, in these two studies, was a reduction of acute kidney injury in the patients who were treated with DAPA or EMPA in these two trials. So even in people with heart failure, where SGLT2s are used for heart failure treatment, there is renal protection as well as a reduction of acute kidney injury. So let us then now turn our attention to GLP-1 receptor agonists. Here are two examples, and of course you know that there are others with dulaglutide, the REWIND trial, etc., showing you that a renal composite endpoint, which uses macroalbuminuria, doubling the serum creatinine in end-stage renal disease or death, there is a 30 to 40% reduction in the renal composite endpoints with either semaglutide or here with liraglutide. Similar data is available for dulaglutide too. However, the important thing is when you break the results down to look at where the predominant benefit is. You will recall that with the SGLT2s, we saw benefits regardless of the GFR baseline or regardless of albuminuria baseline. Whereas with the GLP-1 receptor agonists, what you find is if you look at the top panel, which uses a broad renal endpoint, but more specifically uses macroalbuminuria, then the meta-analysis shows you a benefit, a reduction of 17% in the progression of nephropathy and renal disease. However, if you take out macroalbuminuria, as you can see in the bottom panel, where you're looking at only all the other renal endpoints, you find that the significance is lost. So the suggestion here is that the predominant effect of GLP-1 receptor agonists appears to be further later in the disease journey of renal impairment in type 2 diabetes and is particularly related to macroalbuminuria and progression of macroalbuminuria. So, Mr. Chairman, ladies and gentlemen, my summary is there are still very large numbers of patients with CKD in type 2 diabetes, which is associated with an increase in MACE and heart failure. The recent SGLT2 trials demonstrate a protective effect in all stages of renal disease, from prevention to progression and also from regression. There is a reduction in renal death, and there is a simultaneous reduction in cardiovascular death. GLP-1 receptor agonists appear to have a smaller nephroprotective effect, about 17% compared to 30 to 40% with the SGLT2s. And this seems to occur later in the renal journey when you're talking predominantly about macroalbuminuria and not related to earlier changes of development of renal disease or development of microalbuminuria. Thank you very much, and I'm again grateful for the opportunity to participate in this conference this year. Thank you very much.